May I go ahead? Okay. So, fresh presentation number 9, shifting from intraluminal to subintimal and vice versa. Is it possible? Thanks to ASAHI, of course. And this is my disclosure. I start immediately with a clinical case to better understand the possibility we have with this new wire. Uh, Again, with an 85 years old gentleman with diabetes and hypertension, atrial fibrillation, pacemaker, fraction ejection 30% with creatinine serum 159, Wi-Fi classification 321, and 80 millimeters TCPO2. You can see the bed situation in the forefoot. We performed CO2 angiography, so very few significant lesion in the SFA and popliteal tract. We start to have a problem in below the knee area with the long occlusion of anterior tibial artery, and I can show you the occlusion starts a few centimeters after the ostium of AT, and if we check selectively with the contrast medium, we can see the lesion is quite similar to the CO2 aspect, and this is the situation and the reconstitution of distal anterior tibial and pedal artery in the foot. There is a fistula, an arteriovenous fistula, probably due to the previous surgery in the foot. This is the anteroposterior view with contrast medium of the foot. We can see there is stealing fistula and the flow in the forefoot is very, very bad. So we started to decide to use this new guide wire for the possibility to perform the procedure intraluminal, and whenever we fail, we can shift to a subintimal approach. And this wire was projected exactly for this purpose. We can see here in this picture the characteristics, the features of the wire, which is the new Gladius MG PV, which is an hydrophilic 1,4 wire projected to be easily looped and to maintain the loop very narrow. It's very important to maintain the loop narrow in order to avoid damages on the vessel wall, especially when we try to perform a subintimal, an aggressive subintimal dissection. We don't have to perforate the adventitia, and the adventitia is very, very delicate, especially in below the knee vessel when we have severe calcification. We can see here the features. We have 50 centimeter of hydrophilic coating in the wire and 40 centimeter of polymer jacket in the back, and the tip load is only 3 grams, and this is an advantage because this wire can navigate in an excellent way when we need to navigate, even in tortuosity, even in problematic anatomy. There is a modified distal core balance in order to avoid or to minimize the tip prolapse when we engage the calcification, and the tip could be entrapped in the calcium. Normally, we have the tendency in the wire to create a loop and create a prolapse of the tip, which decrease dramatically the torque and decrease dramatically the possibility to cross the lesion. There is a 3 centimeters radio pack length, which is very, very nice, and the length of the wire is my preferred length is of course 300, because with the long wire we can do almost everything. So that's the wire in action. You can see we start all the procedure with the 4 French Bernstein catheter. In this case, I used directly this wire in order to stay in the true lumen in the beginning, as you can see, because the wire is going in the collaterals. So normally we start our algorithm, our strategy is to always to approach the lesion, calcified lesion, intraluminal, and when it's not possible to advance, we shift to a subintimal. You can see here the creation of the loop, and you can see how this loop remains very, very narrow in the progression of the wire. The wire is advancing with the maintenance of the loop in a very narrow way. This wire is supported by a carnelian catheter, a 1/4 carnelian catheter. You can see here we could reach the distality of 80, so we are back in the true lumen with an no difficulties. The perception, the feeling was to have suddenly a stop in the resistance, and the wire came back in the true lumen. So it was possible to advance. You can see here on the left, to advance the wire till to the pedal artery. There is a tortuosity. The vessel is severely calcified and it's tortuous in this area. So normally we use a dynamic strategy. So we ask the patient to push the accelerator as in the car, or we help the patient to push in order to straighten, to help to straighten the artery in this region. So it was possible to straighten a little bit the artery, and retrieving the loop into the catheter. Look how easily the wire can navigate despite the aggressive looping advancement. You can see here again the wire fighting in the tortuosity, fighting in the anatomical difficulties. The calcium is really severe, and the wire is not new. We can check through the microcatheter the situation, and we decided to try to go ahead, to go forward, to try to approach with this wire and the microcatheter the arch. You can see here the wire is going into the digital arteries of the second, and again into the digital arteries of digital artery of the first. And look, despite the strong and heavy use, the wire has a little damage in the hydrophilic coating. You can see there is a very, very small interruption in the coating, but despite this could be advanced with no difficulties into the digital arteries. So after this, it was possible to predilate the digital with the a 1.5 balloon. You can see here again the advancement of the wire into the digital artery is a little bit better. The patient is moving too much, and we could advance a 2 millimeter 40 millimeter balloon, 2 by 40 and 2 by 80, high pressure non-compliant balloon is a jade balloon from Orbus Nike to crack the calcium and trying to improve the luminal gain in order to redirect the flow in efficacy towards the forefoot. After the final dilatation with the 3 millimeter in the AT, you can see the speed of the flow in the distality, and you can see the nice results with contrast medium, with the blushing effects in the wounded area of the forefoot of this patient. To conclude, you can see here the 2D perfusion angio demonstrating a quite good aspect in time of arrival of contrast medium and in density after the procedure. But what is important is the destiny of the patient that could be amputated with the transmetatarsal amputation. You can see here the nice aspect after the foot surgery, and of course is a very recent procedure, and in 4 weeks we can follow up the patient again. So in conclusion, the Gladius MG PV14 is very, very easy to loop. So creating the loop is very, very easy, no problem at all. The loop remains always narrow, and there is the feeling is to have a very safe wire and a very efficient wire in creating a subintimal approach. Sometimes the impression is that is too easy to perform a procedure with this wire because of the narrow loop. So it's quite easy for a narrow loop to find out the way to re-enter by itself compared to a loop with the tendency of enlarge, especially against calcified obstacle. Then there is a high navigation capability when the wire is straight, when it's not looped, and this is a multi-purpose wire, so we can really use the same wire because the resistance of the tip is very high, it's very durable, so we can straighten the wire after use the loop or vice versa with no problem. Thank you very much for your attention, and we can